Thank you, ladies and gentlemen, and thank you again for being invited to share my thoughts. Could I just have the big slide thing, the slideshow on the screen here, if that's possible? No, the big slide, rather than the slideshow. That's right, yeah, because then I can use the pointer. I think, yeah. Two biases to declare, and I think anybody that gives a talk on caesarean section should declare their biases first. I've got a bias towards a lower rather than a higher caesarean section rate. And have you got my slides? And the second bias, for those of you know me, I've got a big bias towards knowing what you do and auditing. And I think my view is that this is going to be a far more important issue in labour and delivery than randomised controlled trials to find the solution. The caesarean section debate now has been at a standstill, in my view, over the last 20 years, maybe even more. And I think we need to look at a different way of solving the problem. We may have to redefine the problem. I think everybody has got something to contribute, and we've got to incorporate, and I think low and high caesarean section rate institutions have. And discussions about limiting caesarean section rates without taking other factors into account are at best inappropriate and at worst dangerous. So that's my starting point. The other point I want to make is overall caesarean section rates are not helpful. Some of the statements I come out with are very simple and very dogmatic. That doesn't mean to say everything's 100%, but it is a statement, and I think they're not helpful at all, and I think we should stop using them or limit our use. So really, we need to study the epidemiology of all perinatal outcome. We need to classify all perinatal outcomes so that objective comparisons can be made of fetal and maternal outcomes over time in one unit and between different units, both nationally and internationally. We need an alphabet. We need a common language so we can compare and learn from each other. And I think that's where we will benefit most, and in the end, our patients. So we cannot consider caesarean sections in isolation from other outcomes. Perinatal morbidity and mortality, maternal morbidity and mortality, complaints, medical legal cases, staff and infrastructure resources, maternal satisfaction, staff satisfaction, you know, often forgotten, but you know, if we've got good staff, motivated staff, happy staff looking after care, then I think this will show in customer satisfaction from the woman's point of view. And last of all, we can't avoid it, financial. And financial is going to be a bigger and bigger issue, and it's going to be part of our makeup, if you like, to make important decisions and actually to be able to prioritize. We just can't say we want this, we want that, we want this, we want that, and we all are suffering in one way or the other, some countries worse than others, from the economic situation. So we've got to, and that's a good kind of thing actually, to focus our mind. I think the person, I use a lot of golf analogies, and the golfer that's playing for 10 euros when they've only got €5 in their pocket, they're the hungry golfer. They really concentrate. So I think, you know, having to a certain extent some restriction on resources, or be able to qualify why you're using it, is not a bad thing. But to do this, we need a consistent and objective structure within which we can examine fetal and maternal outcomes. And objective is the real issue. There's a lot of things that we do, indications and things, are very subjective. Don't be worried about that. But at the top of the hierarchy, we need a objective, or as objective structure as possible, so we all look at it in the same way. If we are to understand caesarean section rates, just to look at overall caesarean section rates, it just is not the way forward. The principles for a classification system, it's got to be simple. People have got to remember it. We've got all kinds of classification systems in our subject and medicine generally, which are so complicated we never remember. It's got to be easy to implement, and it's got to do the job. It's got to be informative and useful. It's got to be a people's choice, not a guideline committee's choice. People have got to believe there's got to be something in it for them. I like the word with, rather than user-friendly, user-tempting. There's a reason for all of us to use it. And when I mean the groups that we look at, or the structure, they must be objectively at the top and not subjectively defined, and hopefully mutually exclusive and totally inclusive. And what I mean is that it will only go into one group rather than all the groups, and everybody will go into a group. It's got to be prospective, and the reason for that is if you don't have a classification that is prospective, you're not able to, if you want, to go back and change care or look at your care. So it's got to be in some way prospective. You've got to be able to identify the groups beforehand as much as possible. Clinically relevant is obvious, identifiable, totally accountable and replicable. So people have got to be able to do it just as well wherever you do it. So you've got to attract that kind of commitment to it. Universality is very important. It shouldn't be just something that something can do in the country with many computers and sophisticated programs. And in fact, if it does depend on that, I would always be suspicious of that. It doesn't mean to say that it wouldn't be easier if you had it. It's got to be robust, and it's got to be self-validating. Robust meaning that you don't want to change it all the time, and that it's built on criteria that won't change. And if you do it on a specific subjective treatment, and you have a classification or anything like that which may change in years to come, then it's not as useful, because ideally you want a classification that will stay. That doesn't mean to say that you can't add groups together, or indeed make groups mine into the groups and look in more detail, but the fundamental groups, the 10 groups that I'll come to in a moment, or the groups that you choose, has to be a mode of language, a code of discussion, between different countries. And the universality, I think, is very important, that all you need is a pencil, a paper, and very simple knowledge about labour and delivery. And lastly, it's got to be able to incorporate other variables and outcomes, and I'll come back to that in a minute. These are the possible other things: epidemiological reasons, age, body mass index, fatal weight, case mix, previous medical history, indications. We're very good at collecting whether an event took place or not, but indications we're not very good, and that's another discussion again which we need to work on to define what do we mean by fetal distress, what do we mean by dystocia, etc. It's got to be able to include organizational systems on the labour and delivery, and it's got to, as I've said, include maternal and fetal events, outcomes and complications. So the overall objective structure, and within that all the things that you want to look at. Now traditionally a lot of these things have been the first level that you look at. So people say, well, okay, we'll look at all the women over 35 and the caesarean section rate is going up, therefore a 1 + 1 = 2 and women going up. But it's not as simple as that, because there are a lot of other obstetrical factors. And again, it's looking at things the other way round. Within the objective structure, they'll make more sense. That doesn't mean to say you can't look at these factors first, which we've traditionally done, but I think I'll try and show you, or persuade you at least, that looking at within an objective structure would be better. And the philosophy of what I'm going to present, the 10-group classification, which some of you may have heard of, is based on the premise that all this epidemiological information, maternal and fetal events, all this, some of which are subjective, and outcomes will be more clinically relevant if analysed within a common structure. And the 10 groups is what I'm going to present. They're obstetric concepts or parameters. And these are the 10 groups, really. And they really came from 4 really main divisions of criteria. All women are either nullips, multips without a scar, multips with a scar. Now the multips with a scar may have a vaginal delivery or 2 or more caesarean sections, but that's very fundamental. They're the cards that are given to us, and it's very remarkable to me that most people, although it's so important in terms of your activity, don't actually know what the makeup of their population is. We can't do anything about that, but it makes a huge difference to any kind of intervention that you look at. Secondly, a woman can only deliver in one of 3 ways: going to spontaneous labour, being induced, or have a caesarean section before labour. Just like our previous presenter presented, very eloquently, very simple, one or the other. Thirdly, it's either single cephalic pregnancy, a single breech pregnancy, a multiple pregnancy, or transverse lie. And lastly, the gestational age. So they're the 4 divisions. They're very simple, they're clinically relevant, they're prospective, we all identify them. In our minds, it's the first thing that we think of, or should think of, when we see a woman and the labour and delivery. Now, from that, the 10 groups are arisen, and you could say, why 10? Why not 5? Well, the human mind, and we're all decimal, or some of us are decimal and catching up with some of us haven't been in the past. 10 seems an appropriate balance. It's just enough for the human mind maybe to remember by heart. If you have more than 10 groups, you probably won't remember, and if you have less, it will give less information and knowledge about what you're looking at. So a woman is nullip, single cephalic, greater or equal to 37 weeks of spontaneous labour. That's group 1, and there's a reason why it's group 1, because anybody that knows the labour and delivery ward, it's the most important group, emotionally, physically, in every way. It's a large group, 30% of most populations. The inverse of that group is the nullip, single cephalic, greater or equal to 37 weeks, that was either induced or caesarean section before labour. And a lot of people ask, well, why don't you split that up? Well, then we're into splitting up groups and you don't get the overview. That group 2 is the group of women that have otherwise gone through pregnancy, and we intervene. We either induce or we deliver by caesarean. Now, an obstetrician may induce one, and another obstetrician may deliver by caesarean section. And the whole point is, of course, we need to divide it up into inductions and caesarean sections before labour, but forcing people to think of group 2 first, there is a purpose with that. So the actual 10 groups, and the 10 groups is only a starter for 10, as I say. It's to encourage people to look, get an overview, and then divide the groups up. But group 2 is the women that we intervene with single cephalic. And if you just take the size of group 2 over the size of 1 and 2 added together, you will find what proportion of single cephalic nullips that we intervene with. I was very interested in listening to the discussion on induction, and nobody mentioned nullips and multips. It's the first thing I think of every time. In fact, a true story is that I was rung up as master. You get rung up by all kinds of people when you're a master, and I got rung up one day by the vet in the zoo who had a gorilla in labour. And they were running into problems, and they wanted to ask an obstetrician what their opinion was. And 2 o'clock in the morning, whenever anybody rings at 2 o'clock in the morning, they spend the first 10 minutes apologizing that they rang, and the second 5 minutes, trying to explain the case. What do you think my first question was? Was she a nullip gorilla or a multip gorilla? It's absolutely fundamental. Anyway, groups 3 and 4 are the same, but they're single cephalic multips without a scar, spontaneous labour and induced or caesarean section. Group 5 is the big group that we were talking about, single cephalic with at least one previous scar. Group 6 is all breaches, nulliparous breaches, and group 7 is all multiparous breaches, and this in situation including the previous scar, because that's the biggest, the breach is the main kind of indicator for the group. Group 8 is all the multiple pregnancies. Group 9 is all abnormal lies, a very small group but a very consistent size. And group 10 is the reason why most units say that their caesarean section rate is going up, all the preterms with single cephalic that are supposedly high risk. Very quickly, there's 3 ways to look at it. You take the numbers in each group, the total numbers, they should all add up, the number of caesarean sections, the number of deliveries, gives an overall percentage. This is our data from 2010, but it's the same principle. And then you can look at the size of the group. You should always look at the size of the group first. You take the number of the group, the denominator, over the total denominator, and the size of the group tells you an awful lot about that delivery unit, even before you get into any other variable. By the way, my email was at the front. If anybody, unfortunately I've got to dash off after the lecture to catch a plane, but my email was at the front and certainly be available. And if anybody wants any papers or any further information or even slides, I'll be very happy to provide. So that's the size of the group. You can take the numerator over the denominator and it'll give you the caesarean section rate in the group. And lastly, you can take the number of caesarean sections over the total denominator, and that will give you the actual contribution of each group. And that takes into account the size of the group as well as the caesarean section rate within the group. It's not only the section rate in the groups, it's the size of the group, and it can swap between one and the other. Okay, Fundamentally, and I can't go into too much detail here, but groups 1, 2 and 5 contribute to 2/3 of all the caesarean section rates, and more importantly are the source of the biggest variation between units. Now you have to prove that by looking in your data, but that is the big groups, and as mentioned earlier by Aris, groups 1 and 2 are the biggest contributor to group 5. That you have to, well, confirm it first, but you have to acknowledge that until you, before you actually look, in order to try and look and understand your caesarean section rates. Group 6, 7, 8, 9 and 10, all the obstetrical abnormalities, all the bit about evidence-based meds, and all the ones where you do randomized controlled trials, I don't care if you section them all. It won't make a big difference. And remember, the risk-benefit ratio is such that there's far greater risk. You can see here in our population with a section rate of 20%, we're nearly sectioning all of them anyway. The only one that we're trying to catch up is the single cephalic and the high risk. And it's very interesting just looking at that group. If you've got a section rate of 35%, I can tell that that unit has got a lot of pre-labor sections there. Because if you go into spontaneous labour preterm, you all deliver vaginally. So that unit has got a very low size preterm delivery rate overall. Most of it is preeclampsia or small babies. If it was a unit that had a 20% section rate and maybe a 9% size there, they would have a lot of preterm labour. You can just tell that information by just looking at these figures. So there will be 4 distinct clinical entities in the future. Single cephalic nullip, greater or equal to 37 weeks, groups 1 and 2. That is the most significant. That's where we should be doing all the work. And I don't know whether a randomized trial is going to help, but what I do believe is looking at every single outcome in that group, both maternal, neonatal, fetal, knowing that we do things differently, but then learning from each other. Because if I find out that, for example, the section rate in single cephalic nullips is, say, 14% in a country, and they've got very good fetal and neonatal outcome, I'm going to go to that place or to that unit and see what do they do, and try and copy it, or trying to learn, or trying to get some of it. The single cephalic multip is a very distinct group because they just deliver. And inducing a multip rather than a nullip is a completely different process from maternal request, and it's proven. Or if not, look at your figures. So when people talk about induction rates, we're putting apples, oranges and pears in the denominator. They're missing the point. There's only 2 important groups. There's the nullip single cephalic greater than 37 weeks as a group, and there's the multip single cephalic. One you can forget about, or if you want to induce for social reasons or other, the risk-benefit ratio is much less. But single cephalic nullips, remember what we said yesterday about uterine ruptures, and although it was a very entertaining debate or anything, I am very conservative in terms of induction and in terms of surgery otherwise. Single cephalic multip with at least 1 previous caesarean section, that's the VBAC group, that's in group 5, and that's a bigger group. And as I said, I would encourage spontaneous labour, and if they get to 41 weeks or 41.5 weeks and it's unfavourable, I would be very happy to deliver those by caesarean section. I wouldn't give prostin, but wait for spontaneous labour. And remember, the woman, you can't afford to have a rupture in your unit, because if you do have a rupture, it puts back everything. So don't be greedy with the oxytocin, don't be trying to push it. That's my advice. Just wait for spontaneous labour. And all the obstetrical abnormalities, group 6, 7, 8 and 9, 10, it doesn't really matter. This is an important paper published November, Preventing the First Caesarean Delivery, and this is an American paper. And I just pointed out really that they are beginning to understand, and it's good because we will all develop this common language. A classification system is needed to track caesarean deliveries, compare rates between practices, and over time perform orders. Although not uniquely designed for primary caesarean deliveries, this classification is an example of a simple method that allows comparison of caesarean delivery rates between practices. Look, this is just the starter. There is an awful amount of original work that can be done by everybody, but Providing we have the 10 groups, we can just look at it and learn from each other. And the other important development is Canada, in their SOG guidelines, have been the first country to officially endorse the 10 groups, and now in Canada they're going to be looking at the 10 groups nationally. This is a paper that's in press, and it summarizes everything, how you can interpret the 10 groups, methods of achieving and maintaining an appropriate caesarean section rate. And if anybody wants a copy, I would be very happy to send an electronic copy. It's going to be published next year sometime. Probably the most important comment I want to make today, we have for years concentrated on processes, on guidelines and things. My own view is quality, and that's what the woman is interested in, is related to outcome. And I think it's the other way around personally. Outcome will guide processes. Now, obviously in life is a bit of this and a bit of that, but I think we've been far too much the other way. The electronic monitoring, which way are we going to monitor? Which way are we going to do? Does anybody know the outcomes? That's what women are interested in, and that's what I'm interested in. So, final slide, and the email is there. The 10-group classification will allow absolute and relative comparison of all events and outcomes in childbirth in a realistic way, and also allowing for other variables. The risk-benefit ratio will be different in each group. Units that audit their 10 groups will be able to justify their practice and result in appropriate caesarean section rate, whatever that figure is. Thank you very much.